Alrighty, well, welcome. Happy Thursday to us all. We are here to meet today on sensory reactivity in autism and related conditions. My name is Holly Lechniak. I am a licensed clinical social worker with the Arts Center at Rush, which is the Autism Center here. And with us, we have Dr. Paige. Do you say Cyper? I want to make sure I'm pronouncing that right. Okay.
Yep.
Dr. Paige Cyper, who's a licensed clinical psychologist and the chief psychologist at Seaver Autism Center for Research and Treatment, as well as an assistant professor in the Department of Psychiatry at the Icahn School of Medicine in Mount Sinai. So her research focuses on biomarker discovery and sensory processing using electrophysiological and behavioral approaches. Dr. Cyper is also the co-developer of the sensory assessment for neurodevelopmental disorders, or SAND, which is the first clinician administered observation and corresponding caregiver interview to quantify sensory reactivity according to DSM-5 criteria in autism. And so we'll get to hear Dr. Cyper today speak to us about sensory reactivity, help us understand what that is, current treatments, and have some space and time for questions for us today. As I mentioned briefly, if you have questions throughout, you can use the chat or the Q&A feature, clicking anonymous if you would like to keep your name out of view of other attendees. Your names are not able to be viewed or and they are not a part of this recording. With that, Dr. Cyper, you can go ahead and go to the next slide. There we go. Little description, and then go ahead to the next slide again. All right, so today, as I mentioned, we will cover what sensory reactivity is, what it is, why it's important, how it's measured, and again, what we know about treatment. We'll talk a little bit about Spark and an upcoming Spark-related event, as well as have time for questions. Go ahead and go to the next slide. We'll talk about this again, but tied to sensory, we have an upcoming event at a sensory gym in Franklin Park, and we'll chat a little bit more about that towards the end of the presentation. Go ahead and go to the next slide. All right, so with that, I will hand it over to Dr. Cyper, and I will kind of monitor and jump in with questions as they come, okay?
Sounds great. Well, first, thank you for having me here and for the introduction. I'm really excited to get to share with you all what we know and what we're learning about sensory reactivity in autism and related conditions. To start, I just want to disclose, as Holly mentioned, I'm one of the developers of the sensory assessment for neurodevelopmental disorders, which I'll describe briefly during my talk today. So I really want to start by everyone taking a step back for a moment and thinking about their own personal sensory preferences. So all of us have different preferences. There are some of us who work well in a coffee shop and can zone out the ambient noise or work well with music on, the TV in the background. Others of us who need a quiet workspace or prefer to work in a library type setting. We have preferences about our lighting. So some people prefer bright light, some people prefer only natural light or lamp light. And then in the sensations that we feel. So some of us enjoy the feel of the sand and the sound of the ocean. Others would prefer to be in a pool, and others would prefer neither of these things. So I want you to think about the fact that you have these sensory preferences. And now if you were to be placed in an environment that wasn't compatible with what your own preferences were, what that might feel like. So if you had to write an essay or complete a lot of written work for, and you were placed in a coffee shop, but you required a quiet environment to have your best focus, think about how challenging that might feel and how overwhelming that might feel, and that your product might not be optimal, right? That it might be impacted by these environmental distractors. And so when we think about individuals on the autism spectrum, it's really important for us to think about these sensory preferences and how we can adapt environments to make our family members more comfortable. And I think a lot about the fact that, we can now, and I'll talk about ways that we do this, we can measure and assess sensory preferences, even in individuals who have few to no words. And even in individuals who are highly verbal, they may not always be able to describe those sensory experiences, or we may be able to see that an individual feels discomfort, but we may not know what the reason is. And thinking about surroundings and environment and sensations is a really great place to start. Now, sensory symptoms have been described in some of the earliest descriptions of autism, but it wasn't until 2013 that these were finally included as a core feature of autism in what we call the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So the DSM-5, this is where we get our diagnostic criteria. And two things to point out. So one is that there's two domains. There's the social communication domain, where all three areas of difficulty must be present. So difficulty with social reciprocity, nonverbal communication, and relationships. And then 2 of 4 in the restricted and repetitive behavior domain. So this is where sensory symptoms fall. So it means that you don't have to have sensory symptoms to have autism, although many individuals do, and we'll talk a little bit about prevalence as well. Now, the DSM-5 describes sensory symptoms as hyper or hyporeactivity to sensory input, or unusual interest in sensory aspects of the environment. And that really refers to sensory seeking. And so what this framework did was it allowed us to really operationalize these symptoms and think about sensory preferences in these 3 categories. And I'll give some examples so you have a good sense of what I'm talking about here. So hyperreactivity refers to an adverse response to sensory stimuli. So for example, being bothered by bright lights, being bothered by clothes of certain texture or tags in one's shirt, or sand, or the feel of a helmet. In the auditory domain, covering one's ears in response to everyday sounds, insisting on turning off certain sounds. So we hear, for example, hand dryers, blow dryers, vacuum cleaners, sirens are some common sensations that bother many individuals. Hyporeactivity refers to an indifference or under-responsiveness to sensory stimuli. So in the visual domain, this might be a delayed or absent response, for example, to a flickering light going out overhead, to a car passing by. In the tactile domain, this may be in the form of having a high threshold for temperature or pain, so not noticing. If your child or adult child was in pain, or might not notice if they were potentially going to get burned by something that was very hot. And in the auditory domain, a delayed or absent response to an unexpected noise. So for example, not noticing the sound of a siren. So in the hyporeactivity domain, we really worry a lot about safety concerns. In the hyperreactivity domain, oftentimes this can really interfere with an individual's comfort engaging in the world around them, going to certain places or doing certain things or wearing certain things that may bother them. And then sensory seeking refers to an excessive interest in sensory stimuli. So for example, peering closely at objects or flicking objects or fingers near one's eyes, seeking pressure, so liking the feel of tight hugs, or rubbing certain textures repeatedly, carrying objects around with them, mouthing objects, biting objects. And then in the auditory domain, putting noise-making objects close to one's ears, making repetitive sounds. And sensory seeking can certainly interfere with an individual's ability to engage in everyday tasks, in academic tasks, in social tasks, as well as in engaging with the world and with people around them. So why is sensory reactivity important? And I really liked this quote from a paper which described that sensory information forms the building blocks for higher order social and cognitive functions, and that it's not only an additional piece of the puzzle, but rather a critical cornerstone for characterizing and understanding autism. And this really resonated with me. I think if we think about our everyday lives and the impact of sensation around us, of the comfort we feel in the clothes we're wearing on a given day, or our eyes feeling comfortable and knowing when we need sunglasses to block sunlight, and the sounds around us that we can modulate if we're in an environment that feels too noisy and we're trying to make a phone call, we naturally adapt our environments to be more comfortable. And for individuals on the autism spectrum, it's not always as easy as kind of making these natural adaptations that many of us do naturally without thinking about it. Now, thinking about why sensory reactivity is relevant. So this is something that we see in children, adolescents, and adults, both with what we call idiopathic autism. So autism where we don't know what the genetic cause is, and then syndromic forms of autism. So autism where we do know, we have identified a genetic cause. Prevalence estimates are generally up to 90% when looking across studies where we see sensory differences in individuals on the spectrum. And then autism-related sensory symptoms are also described across cultures, across races, ethnicities. And so this is something that really is present across individuals with autism. I also want to focus on some of the research that has shown correlations or relationships between sensory reactivity and a lot of other areas. So adaptive behavior, so that's daily living skills, anxiety. So there's some new research coming out showing correlations between hyperreactivity in particular and anxiety. As I mentioned, sensory reactivity can impact social communication. It can impact eating. So whether it's the textures of certain foods or avoidance of foods that are warm or cold, certainly safety awareness, which I described when describing hyporeactivity, can affect sleep. So needing to sleep with certain conditions, maladaptive behavior. If you can imagine being in a sensory environment that's not compatible with your own preferences, easily can trigger some challenging behavior, and then certainly caregiver stress and trying to manage some of these behaviors and challenges with sensation. I think it's also really interesting to note, I'm going to show some research data, but I'm going to give you the takeaways in lay language. And so I hope that I'm happy to answer questions if you want me to get into more detail. But this is one example of a study that's looked at infants starting at 6 months. And these infants were followed every 3 months up to 24 months. So from 6 months to 2 years old. And these were parent reported concerns. And the groups, there were 3 groups. So there was a high risk group who went on to develop autism, and a high risk group who did not go on to develop autism. So the high risk was defined by having an older sibling with autism. And then there was a low risk group where a baby was enrolled who did not have a relative with autism. And really interesting, what this found was that parents autism. And I highlighted this sensory box here so you can see at every single time point, there was a significant difference between those in the high risk group that went on to develop autism compared to those who did not develop autism in either of the high risk or low risk groups. Now, these symptoms were present even before social symptoms and repetitive behavior. So what we think of as some of the other core symptoms of autism, the social symptoms did not start to differentiate until 12 months. And similarly, it was really 15 months where the repetitive behaviors more consistently stood out as significantly different. There's some other data. So this was from another study looking at toddlers between 12 and 24 months using another measure, looking at the sensory experiences questionnaire, where these differences were also very clear that those individuals between 12 to 24 months in the high-risk group overall, the high-risk group who went on to develop autism, showed an increase in sensory symptoms during that time, where the other 2 groups showed fewer symptoms. Interesting also to think about cognitive level, language level. So sensory reactivity symptoms, these are 2 different studies with different age ranges and pretty large samples. And you'll see that in both of these samples, sensory reactivity symptoms were present across the range of cognitive ability. I also want to highlight, when we think about how do we measure sensory processing or sensory reactivity, that we can measure sensory reactivity from a neural or the looking at brain structure, brain function, brain response. And then we also can measure sensory reactivity in terms of clinical symptoms and observable reactions. And that's really what I'm going to focus on today during this talk. But I think that thinking about the fact that this is something that isn't just an observable reaction, but that there are actually differences in the brain in response to different sensory stimuli. So what are different tools that we use to measure sensory reactivity? So in research studies, we're testing out different types of what we've often referred to now as biomarkers. So we're trying to identify things that are perhaps distinct among individuals with autism or with certain types of autism. So for example, individuals with genetic syndromes. And what you'll see is that, what you'll see is that we're looking at EEG, we're looking at eye tracking, and then in the behavior domain, we've often been reliant on parent report forms. So many of you may have filled out forms such as the sensory profile or other forms asking about sensory reactivity. And so it's something that I have done over almost the past decade, was worked with a colleague on developing the first observational assessment with a corresponding caregiver interview so that we can actually measure sensory symptoms within a clinic setting. So as a clinician, it's helpful for me to use these sensory stimuli to prompt sensory reactivity behaviors, and then also to ask the caregiver who's with the child across multiple environments the same questions that I'm coding during the observation. So just to give a little bit of background about what the SAND is. So we really created this because when the DSM-5 came out, there were no measures out there to objectively measure sensory reactivity. We were relying only on these caregiver report forms, many of which have been used extensively in individuals on the autism spectrum, but weren't necessarily developed for this population, and were not necessarily developed to account for individuals with different levels of language, for example. So we wanted a tool that would be appropriate for individuals of all levels of ability, including those with few to no words and intellectual disability. We wanted straightforward, standardized administration and scoring. So regardless of how old you are and regardless of what your language level is or your receptive language, regardless of how much language you understand, the same assessment could be given. And then we took what we know from literature about gold standard autism diagnostic assessments, where the combination of a clinician administered observation and a caregiver interview really provided the most robust diagnostic picture. And so we created that as part of one measure where we combine the observed and reported symptoms across all the domains and modalities that we look at. And then we wanted a low cost and low burden tool that would be useful for both clinical purposes, for researchers, and across a variety of disciplines, whether it's psychologists, occupational therapists, and others. All right, and then I also wanted to mention, so many of you have likely gone through this process where a lot of information was collected. And so when we were developing the standard, the idea wasn't to take away anything from an existing, from the existing model, but really to add to it, to be able to quantify and give families a really clear picture of their child's sensory preferences in each of these domains. So in hyperreactivity, hyporeactivity, and seeking across visual, tactile, and auditory modalities. All right, so now I want to also highlight that the current conceptualization of neurodevelopmental disorders or autism is really what you see on the right, where the idea is that while the core behavior from the outside can look very similar, and we're looking for certain criteria based on the DSM-5, the underlying causes can actually be very different. So in the world of genetics, and I know you'll hear more about SPARC, in about 20 to 30% of cases, or Holly might correct me there, we can identify a genetic cause. So in those cases, we can, a deletion or a mutation in a particular gene is found to be causing the symptoms of autism. But regardless, every individual with autism is different, right? Every individual comes with their own unique profile, with their own unique strengths and weaknesses. And sensory symptoms are really quite similar. So when we look at sensory symptoms, what we see is that even within the same modality, so visual, tactile, auditory, or within the same domain, hyperreactivity, hyporeactivity, we can see differences at the individual level. So some individuals where there's a particular song that they like and they'll notice it from a mile away, but they can't tolerate the sound of a siren, for example, and may ignore everyday sounds such as a doorbell ringing or a phone ringing, right? So there's lots of different profiles that we see, and that's why measuring these are so important to really personalize treatment recommendations, because what I would recommend for an individual who was hyperreactive and had a lot of sensitivities to sounds, for example, would be very different than what I would recommend to an individual that might not notice a fire alarm going off that implied that they needed to find to remove themselves from the environment. And then I also want to mention, because I did mention a bit about genetic syndromes, there's also a lot of literature coming out from our group and others describing sensory reactivity abnormalities in genetic syndromes. And some of the things I want to highlight are that even within these genetic syndromes, where all the individuals don't necessarily meet criteria for autism, we're seeing sensory reactivity as a common thread that's quite common across the syndromes. But I also want to highlight, this is just some data from the SAND that's really interesting. So if you look on the top left, you'll see names, and these are just abbreviations for different syndromes. So Phelan-McDermid syndrome, ADMP syndrome, FOXP1 syndrome, DDX3X syndrome. ISD refers to idiopathic ASD, so without intellectual disability, with intellectual disability, and then a control sample. And what you'll see is that in all the clinical groups, there's significantly higher levels of sensory reactivity. But when we break it down by domain, we actually see quite different profiles among these single gene causes of autism. So we see, for example, in Phelan-McDermid syndrome, significantly greater levels of hyporeactivity, where we see in ADMP syndrome and some of the other syndromes, much higher levels of seeking, for example. And so this really gives us some clues as we think towards treatment and we think towards personalized treatments or more individualized treatments, and also gives families a sense of what to look for in the presence of a genetic finding. So now I want to shift gears. So I think I've made the case for the importance of assessing sensory preferences. Now, there was a survey that came out several years ago through Autism Speaks, where 8,000 parents were surveyed about what therapies they felt worked best for their child. And really interesting, occupational therapy had the greatest endorsement from parents. So above and beyond speech therapy and applied behavior analysis or ABA therapy, the largest kind of consensus for therapies that parents felt worked for their kids was occupational therapy, which is at this point the gold standard for working on sensory differences. But there's really sensory intervention. So there's one systematic review of a particular sensory integration intervention, but it's limited by the fact that it didn't include individuals with IQs below 65. So what are we kind of doing to try to understand more? So this is a survey that we launched a couple months ago, where we're asking caregivers to complete a survey about intervention strategies that they have tried to really assess what strategies or tools and sensory materials have worked for their child on the autism spectrum or with a neurodevelopmental disorder, doesn't have to be autism specifically, and what hasn't, right? So there's many different sensory tools out there, many different protocols that are being used in occupational therapy with other therapists and at home, and trying to figure out which of these tools, which of these materials, which of these approaches do parents feel actually worked well for their child. And feel free to participate if you're interested. There's a QR code, or feel free to message me after. And then some other things that we're doing in terms of in addition to kind of the existing interventions, thinking about how can we integrate, not just spread awareness, but actually create some type of interventions that can be used on the spot to help individuals on the autism spectrum in medical and in recreational settings. So this is an example of a sensory toolkit that we developed that has been distributed across our pediatric emergency departments to other pediatric specialty clinics and within our community. And the goal really is not just to give individuals the tools, which can be really helpful, especially as a distractor or to help satisfy some sensory cravings and sensory needs. But also it comes with a description of how to use these. So a physician, a nurse, a parent can actually read through these brief descriptions and figure out how they can use these materials, and families get to take these home with them and use them after and continue using them after their visit. We also developed a clinical best practices educational training for treating individuals on the autism spectrum in medical settings. So this is something that is now available throughout our health system, and we're working on disseminating it beyond that. And it was really developed to start for physicians and nurses and staff working who inevitably will interact with individuals on the spectrum and their caregivers. And the reason we felt this was really important was because, as you all I'm sure know and have experienced, kids and people on the autism spectrum require specialist medical care, right? And we don't expect that all of the specialists that our kids need to see are going to have much experience with this population. And to be honest, it's really well beyond the autism population. We all have our own sensory preferences, and many individuals do struggle with sensory sensitivities and sensory differences. So just to get a glimpse of what this looks like, that we kind of the other side of it, and what we're trying to educate those working with individuals on the autism spectrum about. So we're basically presenting evidence-based strategies to help shape these environments to increase the patient and the family's comfort. And I'm showing this because I'd really encourage you to discuss this at doctor's visits, and to feel that you can advocate and know how to advocate for your child's needs. So this is taken from Dr. Friedlander, who's at CHOP. And I really like this because it describes a lot of different scenarios that an individual might be thinking or feeling in a medical environment. So everything from being concerned about seeing a shot and thinking that they'll need a shot, not liking the smell, wanting to turn lights on and off, being curious about what things feel like, or not feeling comfortable in the space, not feeling comfortable on the exam table, wanting to touch things on the wall. And so there's so many different sensory preferences. And when we come into an environment and we scan the room, there's lots of things that look very different than everyday environments in these medical settings. So we really wanted to give providers the tools that tools and examples and ideas for how to modify environments, how to satisfy individuals' sensory needs. So here's some just examples of the environmental modifications. So asking patients and families about their sensory preferences. Wouldn't it be nice to let someone know up front, my child's really concerned about the feel of a shot or the feel of the blood pressure cuff, or my child might not notice if something's hurting them, and that's important for them to know too, because a child with a high pain threshold, if someone doesn't know that they can't necessarily express pain that they might be feeling, that's also very relevant. Being flexible, so having people modify the environment or the sequence of an exam to best meet a patient's needs. If a patient's having a hard time or resisting something, being able to take a break, use a distractor, use a sensory tool, or move on to a different part of the exam, giving choices for what the child or adult may prefer to do first. Having replacement materials ready. So if you see the child's touching things or chewing on objects around the exam room, offering them a tool to use. And then being creative, right? I think a lot of this is about adapting to an individual's needs in the environment and feeling that openness and that willingness to connect and to increase comfort. And then, of course, if there is a private space, minimizing wait times, all of those things can certainly help make the visit go more smoothly. And then we also gave some examples about environmental adjustments, and again, giving you some ideas. So if you are in similar situations, you can advocate and give ideas for how, whether it's in a medical setting or in a school setting or a recreational setting, what adjustments might be made. So not feeling discomfort with metal on someone's skin, so allowing a patient to hold up and explore a stethoscope or the material before being used. If clothing or restricted tags are an issue, allowing someone to bring clothes from home, removing tags from scrubs, bright lights, so being able to dim lights, allowing glasses or a hat. If there was loud noise, offering headphones or finding a quieter exam space. If crowds are overwhelming, minimizing the number of staff in a room at a given time. Feeling the paper on the exam table, allowing a patient to stand. Giving too many instructions can certainly be overwhelming, so using a visual schedule to do one step at a time. If there's an issue with medication, textures, or taste, working with it, helping the family work with a specialist, so not necessarily putting all of that pressure on the parent to figure out how to get their child to take the medication, but really getting families set up with the support they need. And then talking about for hyperreactivity, desensitization protocols. So we want to desensitize children to sounds that they might hear, for example, if an individual needs an MRI or some of the materials that they might be exposed to. And in addition to all this, we also gave a lot of behavioral supports, how to talk to individuals on the spectrum and their families, how to listen, how to use certain behavioral strategies, telling individuals what to do instead of what not to do, how to integrate visual support. So that's all part of this module. So to conclude, the kind of key takeaways here. So sensory reactivity differences are present in the majority of individuals on the autism spectrum and can certainly impact daily life. We can measure these symptoms objectively using standardized behavioral assessments, even in individuals with few to no words. Direct assessment of an individual's specific sensory preferences can personalize clinical care. And here are some of the benefits of sensory assessment. So we can quantify sensory symptoms and sensory preferences, which could impact learning and behavior in the school setting or in recreational settings. We can personalize educational recommendations to best support a student based on some of the results from these assessments, and these could be included in a child's individualized education plan. And then really importantly, using these tools to measure change over time. So whether it's change, what we call in the context of natural history, so just with age, or looking at improvement or changes in the context of implementing a new intervention plan, a new treatment, or any other change in services or environments. And we certainly need future research to really establish evidence-based treatment options to better understand the natural history of sensory reactivity symptoms. So how do we expect an individual with a lot of sensory seeking at a young age, do we expect them to kind of grow out of some of that? Do we expect it to change, to improve over time? Who is more likely to improve? And then understanding how underlying sensory deficits, so individuals who also have vision or hearing problems, how that could contribute to kind of the larger sensory picture of an individual's sensory preferences. And I just want to end by thanking my entire team and to participate in the studies that I.
Wonderful. Well, thank you so much. We will take we'll hold questions until the end. We'll go through and spend just a couple of minutes, probably 5 to 7, talking a little bit about Spark, speaking or related to kind of that need for continuing research and how that kind of ties to some of the things that you're talking about. As I'm going to talk a little bit about Spark. So as you acknowledged earlier, we still have a great deal to learn about autism, and I think the different underlying causes in order to best understand interventions and how those may vary depending on the individual and their autism. Go ahead and go to the next slide. So when we think about scientific research, generally speaking, scientific research, it's planned, systematic. We are investigating using what we already know to learn more. But Spark, so go ahead and go to the next slide. Spark, as some of you may know, is one of those research opportunities. And Spark has 2 main goals. It's the main one being helping us to learn more about autism through medical and behavioral information. We do that through surveys and a saliva sample for DNA analysis. And that second goal is to speed up and move kind of the field of autism research forward. Go ahead and go to the next slide. We do that. So how do we do that? We engage with and stay engaged with many individuals with autism. And then in some cases, their biological parents or siblings when available. And then from there, it's kind of three-pronged. So we are looking at gene discovery and being able to return results to individuals if they want them. They can choose to receive those or not, but potentially getting that individual information on genetic differences within that individual. We're also looking to accelerate research at a scale with Research Match, and that's connecting individuals to research opportunities and individuals to researchers, so that, we're really building kind of this community of autism research participants who wish to engage. Go ahead and go to the next slide. And so I want to highlight, because these questions come up and they may come up as we continue to talk. Spark is not looking for a cure for autism, and we acknowledge and recognize not everybody will receive a genetic result, especially right away. There's still a great deal we need to learn about autism, particularly in the field of genetics. And so right now, best estimates are about 10 to 15% of individuals are likely to receive a genetic result, but we imagine, again, that's going to go up over time. We are not developing genetic tests for autism or using this to inform such tests. What we're looking to do, again, is, as Dr. Cyber was mentioning, understand the different types of autism towards that eye of personalized medicine and better understanding what types of interventions and treatments may work best for an individual's type of autism. Go ahead and go to the next slide. So in terms of who's eligible to participate, rather straightforward, must be in the United States, must be able to read and consent in English or Spanish. I'm very excited to say the Spanish Spark platform launched just a little over a month or two ago. So we're now able to enroll in English and Spanish. And it's a pretty inclusive study in that individuals of all ages and abilities can participate. If they are a child or a dependent adult, they would be registered by their guardian. And if they're an independent adult, they can register themselves and still invite biological parents or siblings to participate. And they must have a professional diagnosis of autism. In terms of, go ahead and go to the next slide. So how families participate. This looks like a lot. It's a relatively short process, but we do hope families stay engaged as they go. So that registration online takes about 20 minutes or so. They consent to share data and enter in that basic information. And then we send saliva kits home. This can also be done in clinic all at once if families prefer, or if they need help collecting those samples. And then what we do is those samples are sent to the lab and they are analyzed through full exome sequencing. Families can complete surveys, or individuals can complete surveys if they choose to. All that helps us do is learn more about, especially if that individual receives a genetic result or is identified as having a genetic difference. We can take that information to compare and learn more about that specific genetic difference. And one key piece to know, go ahead and hit enter, is if families do not receive, or if an individual does not receive a result, these samples do get reanalyzed every year. And so if they don't receive a result right away, it means they may still in the future. And I'll show what that looks like in a couple of slides. Go ahead and go to the next slide. So what have we learned thus far? So go ahead and advance. So you can see kind of the map. This is a national study of all of the individuals that have participated. And I don't know how, but that number is off. We're actually at over 100,000 individuals with autism and their family members who have already participated, which is pretty amazing. And again, at about a 10 to 15% return of results to families. And we imagine that to go up over time. Go ahead and go to the next slide. You can see here, when the study started, we were at 68 known genetic differences, so either single genes or copy number variants. That number is just over 200 right now. So, and the study has been going on about 6 to 7 years. And part of that is because we have had such a large cohort, or such a large group of families who have been able to participate. So the more people who participate, the faster that we can kind of identify these genetic differences and changes. The next slide just shows what that gene list looks like. It's available on the website. And there's clickable information for kind of what those different numbers and letters mean in terms of the gene differences. When a family receives a result, go ahead and go to the next slide. This is what that might look like. Hit enter again. They would be matched with a genetic counselor through Spark or with us here at Rush, and be provided information on what that genetic difference means, as well as what do we know about treatments and interventions that are most helpful for that particular difference. They may be connected to specialists. There's also Simon Searchlight, which is a kind of follow-up piece to Spark for families who do get a genetic result that links them to other individuals and families who have that same genetic difference. Go ahead and go to the next slide. So this is the last one here. In just summarizing what's in it for families. I think, as I mentioned, it's that national community. It is helping us to learn more about autism, and ideally for individuals, helping them learn more about their specific type of autism. They can receive like many research studies, there is a small financial incentive. They can receive up to a $50 Amazon.com gift card code after those saliva samples are sent in, as well as additional gift card codes when surveys are completed. Families and individuals are also kind of kept up to date with what we are continuing to learn, and linked to different access, or linked to different learning opportunities. They may receive a genetic result, as well as personalized reports related to some of the survey information if individuals and families choose to participate in those. We do for children and teens. Again, this study is open to everyone of all ages, but we do have an event really focused on helping families of smaller kids or young teens to register and participate at one of our local sensory gyms. If for some of you joining today, if you are local to the Chicagoland area, and if you're not familiar, sensory gyms are just a structured environment that help kids with special needs develop their sensory and communication and motor skills in a safe and fun environment. So with that, I think that's it in terms of Spark or the event itself. These slides will be sent out, as well as the link to Dr. Seiper's study if you all are interested in participating, as well as the link to Spark, either to register at home or attend the event. But at that, we can go ahead and open it up for questions. Feel free to use the Q&A or raise your hand. If you do raise your hand to unmute, do recognize that your name may pop up. So I would recommend, if you don't want that, to use the Q&A feature. And Paige, we did have one come in earlier, and it was right when you were talking about the sensory differences and referring back to the study. And the question that came in was from a parent of a 19-year-old who mentioned that he met all of his milestones until pretty noticeable meltdowns at age 16 months. Twin sister had no concerns or no issues. And I'm wondering if you can speak a little bit to that in terms of if and I don't know if this is what the question was getting at, but if at certain points in time we see more reactivity start to emerge.
Sure. And I guess I should start with saying that even in the studies that I showed, there's still, of course, individual variability. These are describing on average. It doesn't mean every child was showing sensory differences at 6 months old. But certainly those differences were apparent, even in individuals who did meet milestones, right? So everyone who ends up meeting criteria for autism doesn't necessarily miss early milestones. And so I think that the level of that sensory reactivity can impact an individual's life is also really variable. So for some individuals, it can be extremely impairing, and for others, it may come and go, right? And meltdown certainly can be really related to sensory aspects of the environment, but don't have to be, right? And so, like I said, many individuals show sensory differences, not all, not you don't have to have sensory differences to meet criteria for an autism diagnosis, but certainly it's prominent and yes, can become more apparent at different ages, not always just in very early childhood.
Great. I know one of the other questions that we get often is related to sensory reactivity, particularly when we have individuals who are hypersensitive to different inputs, whether that's sound or light. We get this question all the time related to accommodations and helping individuals cope with those sensory sensitivities, or to help them avoid those sensory sensitivities. And how do you coach parents
Sure.
or
Yeah.
individuals on that?
So I think the ultimate goal is to be able to provide exposure in safe and comfortable ways to increase an individual's comfort in that particular sensation that the individual's avoiding, right? So the longer it goes on that an individual avoids a certain sensory sensation, the more anxiety can go along with that, and the more likely an individual is to continue to kind of resist it, right? And I generally say to kind of pick one target at a time to really focus on, baby steps, small progress, right? And to think about, like, kind of picking and choosing, okay, what are the things that are interfering with this individual's daily functioning, with their ability to engage with peers or in school, versus what's a sensory preference. And if they prefer this over that, then we're just shaping their environment to make them more comfortable, right? So I think there's a difference between intentional environmental modifications and sensitive exposures than kind of just avoidance altogether, right? I think it's that kind of intentional piece and really working on goals one at a time to get a child comfortable, right? If we're trying to if they're sensitive to many different sensations and we're trying to expose them to all these different things at once, we're likely to have less success with that individual kind of facing the discomfort and tolerating it than if we focus on one aspect, one change at a time.
Absolutely. That's such a helpful way to think about it. And I think for the individual sounds less overwhelming, but also I feel like as, parents and whether it's at home or in the school for educators, trying to approach things one by one also feels a little less overwhelming on that side as well. What are some of the most common home accommodations or home supports that you've coached families
Sure.
to integrate?
So, I think it's very individualized to what the child's sensitivities or sensory seeking behaviors are. When it comes to sensory seeking, a lot of times the focus is on finding outlets where rather than trying to take away the sense, kind of completely get rid of that sensory seeking, finding where is it okay to engage in the sensory seeking behavior, right? So kind of an outlet for those that desire for that input. And then certainly if there are things that are interfering socially or with functioning, figuring out how can we kind of replace those sensory seeking behaviors, right? So whether it's through the use of tools or through the use of different sensory materials, how can we give kids the sensory input that they're looking for in ways that that are more adaptive, right? Certainly, I know a lot of parents ask about kind of like sensory spaces and right within their homes. And my perspective is I think every child benefits from a safe space that they can engage with materials and interact with really without concern about getting hurt, without kind of the constant reminders and be carefuls that we often give to our kids, right? So I don't think that it's about the particular materials that are in a space, but certainly having that space that's an environment that's fully comfortable to the child and safe for the child can certainly be helpful, I think, regardless of what an individual's sensory preferences are. And then I think in terms of those sensitivities, kind of just as I described, really focusing on one at a time. When I think about that slide where I showed all different types of environments and materials, and if you were someone who, did prefer natural light and preferred a quiet work environment and didn't like the feel of sand, and all of a sudden you were told you were like taken to the beach, you had to work in an environment with bright lights and with a lot of background noise on all at once, that would be extremely overwhelming, right? Versus kind of making one environmental change at a time.
Absolutely. And we had one question come through with related to maladaptive behaviors or, for example, property destruction. So what might you suggest for families or parents to do in response to if they're seeing property destruction and maybe as a form of communication that they are not coping with the environment, but how might you coach a parent or a family to respond?
Certainly. So I think that when you get to that point, I think my biggest recommendation is to get a behavior therapist in the home or in the environment where the destruction is happening. So an ABA therapist or behavior therapist can do what's called a functional behavioral assessment, an FBA, to really try to figure out what are the antecedents, what are the consequences, right? They can kind of break down the behavior to figure out what's triggering it. Is it sensory related? Is it what's the what's the individual getting from that sensation of doing it, to then really come up with a treatment plan, which generally is very behavioral in nature, to try to help the individual become more comfortable in their environment, certainly. So looking at an individual's sensory preferences could help. But I do think having someone with that type of training in the environment where the individual is engaging in that behavior can be really helpful.
Absolutely. And I think all behavior really is a form of communication, and
For sure.
helping when you say functional behavior assessment, that's really just figuring out what that behavior is communicating.
Exactly.
So what's happening right before, what's happening during and after, and better understanding what is that property destruction communicating or trying to communicate. Absolutely. Great. Well, if there are no other questions, we will stop there. Paige, Dr. Cyber, I want to thank you so much for joining us today and sharing your expertise and knowledge in this area. And I'm going to go ahead and stop recording. There we go.